So today we are going to be focusing on community engagement. So our first presenter is Miriam Miller. She's the project manager and community engagement coordinator for the CTSI Community Engagement Corps. Miriam will give us some information about the work that they do and the services that are available to help folks with their research. Then we'll hear from Dr. Jessica Thompson, who is an assistant professor in health policy and administration and a co-funded faculty member of the Social Science Research Institute. She is an expert in community engaged and mixed method approaches to uncover the relationships between social, environmental, and contextual factors affecting chronic disease among women in Appalachia and rural communities. Dr. Thompson currently has a National Cancer Institute funded K99/R00 entitled Reducing Lung Cancer Risk Among Appalachian Women Using Community Engaged Intervention Research. This presentation will focus on her work utilizing community engaged approaches to uncover risk factors and associated interventions to improve lung cancer prevention among Appalachian women. Specifically, Dr. Thompson will describe mixed method findings, including participatory approaches to inform lung cancer prevention strategies that take into consideration social, household, and community factors for women in Appalachian communities. I'm going to put in the chat a link to our YouTube channel, where we will post the recording of this session after the presentations. You can also go back and look at prior sessions that have been recorded if there was a TSS seminar that you really wanted to watch and that you weren't able to attend. So with that, I'm going to turn it over to Miriam, who's going to get us started. Miriam?
Thank you, Jess. I'm just
Mhm.
going to try to share. I think I can share over? Yes, there we go. So I wanted to do just a quick introduction into our Community Engaged Research Corps. This is part of our Penn State CTSI, and the Corps works together to kind of uplift community engaged research across Penn State. We have co-leads, which are Dr. Deepa Sakar and Dr. Alexandra Zagierska, as well as we have a staff. There's 4 of us total. The community engagement team, which was formerly the team known as CHEER, if you've worked with us in the past. So we're all here to help connect researchers and community members and community vendors with researchers. Our CIRC team is faculty across both Penn State College of Medicine as well as University Park. And Bonnie Kent is our fabulous community perspective and partner. She gives us some great insights. And Dayu Pan is our CIRC fellow for the year. So we work together to kind of help uplift community engagement across the campuses. So our CIRC services, Jessica highlighted a couple of them. Our community engagement studios, they are a really great way. It's a small group, but a big impact. You get to share your research project and community member related questions and gain valuable community perspectives back. And that could be on recruitment, study design, implementation, dissemination. Typically, this is a 90-minute, can be a 60-minute session, small group, 8 to 12 people. It's not research, it's more part of planning your project. So no IRB is required, and it's low cost. It's just $75 per participant for a 90-minute session. So if that is something you're interested in, please reach out. Other services as well, as we do consultations on community engaged research or projects or grants that you're working on. We'll provide letters of support. We have presentations, our community engaged research fellowship. Our community-driven research day is something that we've done every year, the last several years, to kind of connect specifically with a community in Pennsylvania that is, and hearing more about them and trying to partner with organizations and organization leaders in those communities. Our health policy team does some great podcasts, and we have community engaged research toolkits, which are on our Penn State CTSI site. That site is being updated, so once that all gets up, our links will be great for that. And then I just wanted to kind of finish up with, this is our QR code. This is really easy if you need to grab this right now for our CTS Research Services request form. And that's your way of getting any of those services I just shared. Complete the CTSI request form, and we'll be in touch to do a consult and answer any questions you might have and help you set up with whatever's next. So thank you so much for allowing me that few minutes to share, and I'm going to pass it over to Jessica Thompson. Looking forward to this.
All right, thanks, Miriam, and thank you all for attending today. I'm excited to share a bit about the work I've been doing. I'm fairly new to Penn State, so it's always nice to meet new folks. I'm about a year and a half in, I think. So hopefully stay if you all have questions. We're a small group, so if you want to throw them in the chat or interrupt me, I don't mind. So just raise your hand or whatever if you want to sort of stop and pause along the way. I am going to be presenting some work I've been doing over the past 2 or 3 years, actually. So this has been an ongoing project that is mostly funded, as you heard, by my K99R00, really focused on improving lung cancer prevention for women in our Appalachian communities. I did want to give you all a little bit of an agenda so you could see some of the things I'm going to be sharing and discussing today. I will start out with some background, give an overall big picture of what lung cancer and lung health looks like among Appalachian women and why am I talking about this particular issue. And then I'm going to highlight some findings from actually 3 different aspects that we've been looking at. So one of those is more focused specifically on community perceptions around lung health and lung cancer. One was looking at, well, what interventions have we already tried? So you'll get to see a little bit of that information. And then taking that back to the community to actually say, okay, what do you think about these existing interventions and how might we want to strengthen or improve those moving forward? And then I'll wrap up with some next steps in future directions. I did want to introduce myself since I am new still. So I am actually from East Tennessee originally. I moved to Nashville for undergrad and stuck around there for a while. I did my graduate training there. I'm actually in community-based research. So that is my foundation and where I come from with the work that I do. I stayed around and worked on a community engaged trial there on obesity prevention. And as you heard, chronic disease prevention really is the core of the work that I do, largely with women and children. I then went to Pitt for my PhD program, so spent some time then in Appalachian, Pennsylvania, and then moved back down to Kentucky for my postdoc training. And I was in the Cancer Institute there. You'll get to hear a bit more about how that work overlaps with what I'm doing here. So the K99 spans both UK and Penn State. I always start defining Appalachia because I'm not sure that everybody's always familiar with this government-based designation that we have for the region. So it currently includes 420 counties, 23 now counties across 13 states. We have 52 of our counties here in Pennsylvania. And what we think about related to Appalachia is usually the rurality here, right? So we have more folks living in rural areas than compared to the rest of the country. We also have socioeconomic related disparities. So thinking about high poverty rates and things like that that exist here. And while there have been some improvements on this aspect in the region over the past few decades, we are unfortunately not seeing the same improvements in health. And so what's happening is we're actually having diverging mortality rates from the rest of the country. And that's even including the COVID spike that you see towards the end of this graph. And so why? What are the health conditions and issues that are causing this difference in life expectancy that we are starting to see compared to the rest of the country? And of course, there's a whole host of health issues that contribute to this, but the largest portion is actually due to differences in chronic diseases, including cancer, and the largest disparity actually exists in lung cancer. So I wanted to share with you a little bit of background about that as well. We'll be talking about women today, so I'm showing the incidence map here for females in this data set, showing you that, as you might expect, some of the highest rates in the country do follow along our Appalachian region. So why is that? What do we have here that is causing this risk? Well, of course, we know we have high smoking rates. I just picked some example states here, and I'm highlighting Kentucky and Pennsylvania, where I'm doing some work. There are actually others in the top 20 as well. We also have high exposures to environmental factors. So radon being the other key risk factor for lung cancer. We're actually number 3 here in Pennsylvania in terms of radon risk in our communities. And again, these are just some example states. There are others that are in the top as well. We also have quite poor smoke-free air laws throughout the region. So 7 of our states have an F ranking. This is an A to F scale that the American Lung Association does. And of course, 3 with a D. So we have lots of improvement that can be made in this space. And of course, we know that there are specific industries that exist in this region that affect lung health. So we might think of mining, fracking, manufacturing, farming, the various factories, agriculture, all of these things that exist in our Appalachian communities that can affect lung health. And you might be thinking, well, these affect everyone, not just women. So why is Jessica talking about women today? So I wanted to give you some background data around this as well. So in the US, lung cancer has actually been declining since the 1980s, pretty steadily. But if you break this apart by gender or sex, as you can see in this graph, this is actually being driven by steady decreases among men. We're not seeing the same decreases among women, unfortunately. And this graph only goes through 2017, but actually we now know that these two lines have actually crossed. So this happened in 2023. This I'm showing you here is estimate data from last year, from 2024, where this continues, where we now have more incident cases of lung cancer each year among women than men in the country. So this has now flipped. We also have certain pockets of the country, including Appalachian areas, where we actually see increasing rates among women, which is alarming. And we also know that women experience lung cancer differently from men. So whether you're talking about risk, diagnosis, prognosis, there are differences. And just one example I like to share is that 20% of women with lung cancer are lifelong non-smokers, and that's twice the rate that we see among men. So there's certainly data here that sort of directs us towards thinking about what can we do to improve primary and secondary prevention around lung cancer for women? And in some of these really high-risk communities, like in our Appalachian areas, what culturally specific things might we want to consider to really help improve this in those areas? I also want to say that this is data. This also came from the community. So when I started working at the University of Kentucky at the Markey Cancer Center, we were doing a new community cancer needs assessment. The Cancer Center's catchment area is the entire state. So we were actually doing this work throughout all of Kentucky. And we were working with this wide range of partners that you can see here on this map. We also had what we call our cancer control specialists, which are community health workers plus. They do a lot of work out in our Kentucky communities. And we were collecting data from both the partner and community member perspectives on where should we be prioritizing our time over the next 5 years. And what we heard was a real need for reprioritizing smoking as the #1 risk factor that they raised that we should be addressing. And then in terms of screening areas, likewise, lung cancer screening was the #1 area they wanted us to prioritize. So this really came from the community as well, like seeing this rise up as a really important area of focus, at least in Kentucky, but thinking this might reflect other Appalachian areas, including the disparities that we see in our rural and Appalachian communities. So when I learned this from going through this process, I said, okay, well, what data do we already have that we could start to tackle looking at this particular issue? And I found an R01 that had just wrapped up at the University of Kentucky. That's actually a fairly large cohort study that enrolled Appalachian participants that was looking at respiratory disease. And I saw that they had some variables on economic, social, and behavioral factors. So I said, hey, would you have any interest in me doing a secondary data analysis to look at what this looks like for the females, because they collected sex in this sample? And they said, sure. So I wanted to give you a really quick snapshot of some of the interesting data that I saw within this population. So this first variable here is just context. So around 80% of the sample was under 65. We only had about a quarter, just over a quarter of our participants who were employed either full or part-time. So we had a lot of folks who are not currently employed. We did have around a third who self-identified as a homemaker, and we had almost 14% who said they were on disability. So we have a lot of folks who are not out in the employment space. And this is reflected in this next variable where we asked about, on average, how many hours do you spend outside the home per day? And over 20% said 0. We then had another, nearly a third, who said 1 to 3. So that's over half the sample was reporting spending 3 or fewer hours of the day outside of the home, which I think is really interesting context. We also had nearly a third of the sample who said they were currently smoking. This is actually high even for Appalachian communities, which are often in the 20 to 25% range, which is still higher than our national averages. And then we had a vast majority who said they'd ever lived with a smoker. So thinking about that secondhand smoke context in the home. And then interestingly, we had almost a quarter, a little over a quarter of our participants who said they already have one chronic condition. And then we had 40% who said they have 2 or more existing chronic conditions. So that's something we are starting to see more in the data as well, these high levels of chronic conditions in this population. And it was interesting that when we then ran these analyses, that everything you see here in bold was actually associated with those adverse lung function measures. So it really suggested I needed to be thinking about, what's happening at the household level, at a residential level. We also notably did not have occupational exposures for those who were employed. This particular study did ask about mining and some agricultural jobs, but nothing that really a lot of the female participants in the study were doing. So that's something that was really missing, along with some of these broader environmental contexts that could be important. So this really set the stage for the work that I wanted to do from this community engaged point of view. I use this slide to kind of set the stage for anyone who's maybe less familiar with this terminology around community engaged research, which is really an approach and not a specific method. And often those of us in this space are doing lots of different types of things because, of course, we're trying to use the methods that best help us answer the questions that are coming from the community. And so in this particular set of data I'm going to be showing you, there's a lot of different types of methods I'm employing. And these are just some examples. I'm sure those of you, if you're doing community engaged work, use other things that I haven't put on this slide, but just to set the context that really we're trying to gain information from a lot of different sources and a lot of different ways to answer these community questions. So here's what I did. So let's start with the concept mapping piece. This was really, again, around capturing community perception. So I'm going to show you briefly some findings from this. Then we have that scoping review element I mentioned, where we looked at existing interventions. And then what I'm going to spend most of the rest of this talk on will be this step 3, where we then took those interventions back to the participants to get their perceptions on this. And actually steps 1 and 3 here that you see on the screen are participatory. So concept mapping is a participatory method, and I'll talk a bit more about that. And then I used a group model building informed approach in the focus group portion of step 3 as well, which is also a participatory method. So maybe that'll be interesting to those of you who do community engaged work if you're not familiar with these participatory approaches. All right, so I'll start with the concept mapping briefly. So this was in Kentucky. We recruited 71 Appalachian women. Concept mapping, in addition to being participatory, is also a mixed method in and of itself. There's actually 3 different points in time where we connect with participants. The first of these we call brainstorming. So we ask, what are all the factors, good or bad, that affect lung health for women in your community? And they could list anything that responded to that question. And then this particular project, I think we ended up with 70 unique items that responded to that question. And we then have the participants sort and rate all 70 of those items. So sorting is what it sounds like. You take each item, you put them into piles that make sense to you, and you give the piles a thematic name. And then rating is Likert type rating scale. So we asked the importance of this around behaviors to keep your lungs healthy, and how feasible would it be to actually address this for women in your community. So this is the data that we use to build the concept maps. I'm going to show you one on the next slide. And the really truly participatory part of this, and that I love, is the interpretation step. So we actually take those maps back to participants. So rather than it being me or my research team saying what we think the maps mean, we actually have the community as part of that. So they are telling us, why certain things were sorted together, or why certain things are rated a particular way, and they are adding that interpretive lens of the analysis alongside us, rather than us doing it separately from that community feedback. Okay, so here is a concept map that resulted from this process. I'll kind of walk through it. This is a combined point and cluster map. So the points are the dots that you see on the screen. The numbers are telling you which item it is. So you'll see 1 through 70 on here. And this is based on the sorting data. So essentially, the closer together the dots are on the screen, the more often our participants sorted those items together. So it is a map of similarity, and we can see how things start to group together, and that we're more often sorted together. So we layer on that a cluster analysis, and it showed us that this broke apart into 8 separate clusters or thematic areas. I didn't name these. So again, we take these back to the participants. We have them talk through in those qualitative group discussions, why do you think these items were sorted together in a particular cluster? What do they have in common? Would you call this cluster? So they helped name these. So you can see there's community factors here, healthcare, social norms, of course, tobacco use, environmental factors, health conditions, and genetics, all playing a role in what they perceive as affecting lung health. And I think this really sets us up in terms of moving towards a broader conceptual framework of what areas should we be thinking about for interventions that could improve lung health or prevent lung cancer. So we'll come back to this in a minute, but next I want to tell you about this scoping review that we've done. So we did scour 5 different databases. We also looked in the gray literature, looking for any studies that had been done with adult Appalachian women that involved some sort of lung cancer risk reduction or prevention. And we ended up with going through all of these studies, finding only 21 that actually specifically focused on this population. So I'm going to give you now, layering on the concept map here, a snapshot of what those interventions look like. And this will not surprise you, but the vast majority of these were tobacco cessation oriented. These were largely individual level interventions, mostly with younger adults. So those of reproductive age or those who are currently pregnant, fewer studies later in the life course. They mostly used in-person strategies. This is a combination of one-on-one and group sessions, and phone call-based strategies. We did see some growth in the more recent studies in using technology. So there was at least one with a mobile app, and then it involved telehealth as well. So a little bit of that growing in the more recent literature. The next most common thing we saw was making improvements in healthcare. And you'll see these numbers don't add up because several studies were multi-level and actually did multiple of these different elements. And these involved things like training for community health workers or health educators, training existing healthcare providers, or helping to improve clinic processes. So in terms of tracking patient data, usually around tobacco cessation. And then finally, there were a couple that were at a broader community or policy level. We did see a few that touched on smoke-free laws. Those actually ended up in that physical environment cluster, which is why that arrow's down there. We also saw community media campaigns with the health communication approach, and then one that involved community pharmacies. So that's, again, like a snapshot of what these 21 interventions looked like. I did also want to share, because I think this context is important, some common thematic findings from those 21 studies. So what did they uncover and what do we know already? So those that looked at tobacco cessation, we saw high levels of relapse among women, and that's even amongst the studies that compared men and women. We saw higher levels of relapse. The interventions that focus on pregnancy specifically largely did show reductions in preterm births and low birth weights, which is great. But most of these studies did, again, not follow later to see subsequent chronic disease risk, lung cancer risk. We just didn't have that kind of data in these studies. Most effective strategies met participants where they are. If you work in rural or Appalachian communities, this is not going to be surprising to you, but if you use strategies that meet people in their homes or in their community or use technology, you're more likely to be effective in these interventions. And then women are responsive to environmental cues. So for example, several of these studies mentioned that women in their studies were not just interested in improving their own health, but the health of their children and their families and their broader community, and really advocating for the idea that things like public awareness campaigns and community level interventions may actually be more effective among women. We also heard some common barriers and facilitators within these studies. So anything using more participatory or social support strategies was more likely to be successful. Those that used non-physicians to share health information, so nurses, midwives, community health workers tended to be more successful. And then aspects that help overcome access and cost barriers. So whether they had things like free or low cost nicotine replacement therapy, or use some sort of technology strategy to help reach people. But far and away, access and cost was still the #1 barrier we saw in studies. As I mentioned, high levels of chronic and mental health conditions is another commonly referenced barrier in these projects and how that complicates or adds to this particular situation. And then reference to the complex generational and social norms around tobacco use in particular was also a commonly referenced barrier and still exists in many of our communities. Okay, so I will spend the rest of my time here for the next 10 minutes or so sharing with you what we heard from the community about what they thought of these existing interventions, as well as, more importantly, what we might want to consider doing moving forward. So we did a combination of a survey and focus groups, as I mentioned. The survey involved lay summaries, so we had a sentence or two at the 5th grade reading level for each of the 21 interventions. Participants could then rate those interventions, again, there's importance for the community and how feasible it would be to do the intervention in their community, and then pick the ones they liked the best or least within that. We then asked them to participate, thankfully, and they did. These focus group sessions, which I mentioned were group model building informed. If you're not familiar with group model building, it is a participatory approach that's often used in system science. Folks use it to build system dynamics models. You'll see they often yield causal loop diagrams, which I'm going to have an example of on a slide here in a second. But the idea here is as well to get involved the community in helping to identify what variables are most important for you to consider. How do these variables relate to each other? And how do we think about that in terms of building a model? So rather than us as researchers doing it on our own, we're actually involving the community in this process. So you're going to hear a bit about that. And in particular, I'm going to be showing you today some data from this 4th activity that we did called Places to Intervene. So I'm going to show you the suggestions that participants had about how we could intervene in different parts of this model. Really quickly, just so you get a sense of what the survey data look like, these are the ratings, these are the top rated interventions from these participants. Again, these are Likert type scales. So 1 is not at all important or feasible, and 5 is extremely important or feasible. And we had 2 at the very top here that involved individuals who currently smoke and are also pregnant. One of those involved nurses in a clinic setting, and another involved counselors out in a community setting. We also had 2 interventions that were highly rated, focused on any individuals who smoke. One of those was actually the mobile app we had in this list, which I thought was interesting. And then another that actually used community health workers doing sessions out in the community. And then we did have 1 intervention towards the top related to provider training. So this was around tobacco treatment specialist training, motivational interviewing, as well as improving clinic processes, as I mentioned, around tracking tobacco. So I also want to point out here, we do not see, these are all individual level or clinic level tobacco use focused. We don't see interventions related to free policies or secondhand smoke, radon related interventions, or those that typically tackle some of these complex social and cultural factors. So that's really missing from these highly rated interventions. Okay, the next slide is the causal loop diagram. If you're not familiar with seeing these, don't get bogged down by all the arrows. It looks like spaghetti. But I did want to show you before we start talking through the different sections what it looks like as a whole. So these are just the most important variables. These are not the only things we talked about in our sessions. But to show you that these cross, of course, primary and secondary prevention, we've got tobacco-related variables here, smoke-free law, radon, and of course, over in secondary prevention, variables around lung cancer screening. So I'm going to start talking through some of these different loops. I want to focus on the ones we actually don't have interventions around, but before I do that, I at least wanted to show you what the participants said about tobacco use and tobacco cessation, so you have that context. So what I'm going to show you is these boxes are going to pop out with what participants suggested we could do to intervene in these particular areas. There'll be some text that's bold. Those are the ones that were most often raised in our conversation. So what did participants think about addressing lung cancer risk? So interestingly, women in our groups, more often we're talking about this from the perspective of youth than themselves. So the #1 thing they were raising was, how do we update the school-based education programs we have on tobacco? We need to incorporate vaping, for example, but also the way we are sharing that information. How do we modernize that? It was a big conversation that we had. We also spent a good amount of time talking about existing tobacco cessation strategies, and largely we heard positive feedback on these. If anything, folks were just expressing could we have more availability of some of these in their communities? But I'm highlighting these 2 points at the bottom because I think they reflect some of what we've discussed so far. Many of our groups described this need for more regular sustained touch points among those attempting to quit. So thinking back to that relapse issue we were mentioning, many of the interventions that were cessation focused were pretty short, sort of 6-8 week programs that they had learned about, and they felt like this was not enough. We need more sustained touch points beyond that. And then we talked quite a bit in our groups about providing a menu of options for those who are quitting, who might have different needs. This often came up in relation to the mobile app idea. Some folks were really excited about it, others less so. And then this sort of notion that it might work really well for some people, but not as well for others who may more want that social interaction they would be missing. So how do we have more of a menu that let people choose what would work best for them? We did talk quite a bit about this social aspect, not as much consensus here, but quite a bit about how we help folks build social networks of non-smokers, sort of reducing that peer pressure, again, a bit more youth-oriented, I think, in some of these conversations, but important factors to think about. And then we talked a bit about this sort of policy aspect. So the bans for underage purchasing, cigarette taxes, keeping that cost high, so affecting motivation to purchase because it's expensive. But again, more, I think, is the theme here. Can we further restrict, for example, where cigarettes and vapes are sold? People still see that everywhere in their community. So that's something they highlighted. Okay, so that's again, an overview of the tobacco use space, particularly cessation. I'm going to talk still about tobacco, but now from a smoke-free law perspective, where we don't have a lot of interventions to reference here. So really the feedback we heard here as well was more. So we did hear positive feedback about some of the policies they had seen in place. They'd like to see, for example, more regulation around chewing tobacco, which many of our participants said is pretty common in their spaces, in public areas. Vaping, of course, was something that came up here as well. Probably the most common thing was hearing folks say, we need to increase smoke-free public spaces even more than we already have done so. As you've heard, these policies are not great in our Appalachian states. They're enforced at varying degrees. So in some communities already, some of these places might have bans, but many of our communities don't actually. And so notably up here in Pennsylvania, the #1 thing that came up was actually casinos, just if you're interested. And then another thing that came up that was important in this conversation, so this particular sample had a mix of non-smokers, former smokers, and smokers. And our folks that don't currently smoke really highlighted, I might not smoke now, but I live with people who do. How do I build skills around helping them to quit or helping to implement smoke-free areas in the home? So again, thinking about what's going on in the household related to smoke-free or secondhand smoke exposures. So I've got some quotes in here. The age restrictions, you can't smoke in public buildings, in a movie theater, and restaurants, making it more and more difficult. It's great where these things are being done. So again, that variability and enforcement, and in Kentucky, for example, there is not a statewide law at all. So it's really up to those different counties and municipalities, and it just looks different when you're going from county to county in terms of what you can and can't do. And then in terms of more, here's an example in schools. I noticed at athletic events and it's halftime, a whole group will go right outside the gym and smoke. And if you walk outside, you have to walk through the smoke. And the same at hospitals. And this commonly came up in many of our groups in terms of this idea of like, okay, great, we've made the building smoke free, but now we've moved the problem right outside. So I was really excited to hear largely positive, motivating conversations around this, women really being interested in how they could get more engaged in advocacy in this space. And I think it's something we could really build on to make some improvements and difference in these communities. All right, next, radon risk. So this may or may not surprise you, but virtually none of our participants knew about radon. So the vast majority of this conversation was around how do we improve awareness of what radon is and how folks can actually test their homes for radon. So you'll see many things here that are certainly awareness building aspects. For example, we spent a long time in some of these groups talking about, well, what's the best way to share this kind of information today? Like, should it be ads on streaming platforms? is sort of skeptical about social media being the right place to share this information today. Should we go more old school? We have people talking about newspapers, putting it in mailings they already get, like your property taxes or weekly ads we get in the mail. And the same kind of thing with the test kits. How do you get them? So could you get them from your real estate agent? Could you get them from your healthcare provider? And actually, the most common suggestion was making them more available in local stores and community locations. Home improvement stores is the number one raised in these groups, I think, because you're already thinking about your home, but we also heard libraries, community centers, grocery stores, places like that. We did have some conversation around policy. Largely, I would say these more focused on the cost aspect. So the cost of the radon test kits themselves, but then also the greater cost if you need to mitigate and supports around that. So again, here's some quick quotes. My 20-something kids, I'm sure if I said radon to them, they'd be like, what are you talking about? So just the lack of awareness of this. And then I like this quote because it summarizes the challenge around addressing radon risk. When it comes to your house, like mold or radon, there's a tendency to say, I really don't want to know because it's too expensive to move or to mitigate. I don't want my house condemned. So that you're talking about the place where people live. Do you want to know there's a problem when you know you can't afford to fix it, you can't afford to move? Would you want that hanging over you? So this is something we do here when it comes to this particular issue that we might want to think about in terms of how we then approach intervening in this space moving forward. All right, the final area I'm going to talk about is lung cancer screening. Again, I would say the majority of our participants did not know that lung cancer screening existed. So we once again talked quite a bit about how do we build awareness of lung cancer screening, recommendations around creating educational materials on signs and symptoms, especially these differences that could exist for women. But I would say there was an interesting undercurrent of frustration in these discussions that most of our participants had not had a conversation with their healthcare provider around lung cancer screening, and they wanted to know why. Now, I think because a good majority of our participants being non-smokers or former smokers, they probably aren't eligible. They probably don't have the smoking history to currently qualify for lung cancer screening, which is why their provider wouldn't raise it to them. But then we'd hear folks say things like, well, okay, but I might live with folks who might be eligible. I should know what it is. I should know how people get to it if they need to get screened. And also, if I've lived with smokers my entire life, even if I'm not a smoker, why can't I also get screened? Or how can I then get that screen? Can my provider help me with that? Another big key for this conversation was folks really recognizing that in our rural communities, many of the hospitals and clinics actually don't have the capacity to do lung cancer screening. So talking a bit about, well, how do we overcome that? Is it using, for example, mobile units, which some of them have seen, for example, mammography vans and things like that. So they're familiar with the idea of could that work in this space? I actually think some universities are testing this right now. We just don't have that data yet. Or other ways to build that capacity in local clinics to do this work. And then raising this issue of community health workers, which is another, again, common thing we hear around health issues in rural and Appalachian communities, that this is a successful model to help build awareness and access. They've seen this work for other types of cancer screening, so doing it for lung cancer screening as well. So, finally, we talked about insurance and costs and guidelines and sort of what that looks like moving forward and the challenges that those can pose as well. So quick quotes, I think community health workers are really important, especially in communities that may not have as much trust in a medical setting. I think it needs to be clear who is eligible because right now it feels kind of vague. What does insurance cover, right? That awareness piece, and the actual ability to do the screens out in the community. And I think a big part of that is transportation, which is a common barrier. But how do we actually get screening to folks in these communities? So to wrap up, how do I summarize this? What are we thinking about moving forward? Well, so moving beyond the individual level, I think is particularly important based on what we've heard. Of course, we've got some great things we're doing around tobacco cessation. Maybe it's more about revamping the way that's presented in terms of this menu of options that participants wanted to see and that community health worker support that's more consistent for them over time. could improve that space. But it really sounds like we need to spend more time developing out these sort of family or household level items. Again, we heard that skill building desire to help others who live in your household, whether it's quitting smoking, getting to screening, implementing smoke-free zones in your house, or doing the radon testing and mitigation. And then this broader community and policy level is extremely important as well. And we certainly heard the need for more awareness on a lot of these issues and interest in advocacy as well. And how do we incorporate that into interventions moving forward? And I think if we can come up with a plan to do this, it would much more align actually with the concept map that I showed you earlier on, really tackling more of these social, environmental factors and community level factors that are a part of this puzzle that we need to be considering. So I'm going to wrap up with this quick next step slide, just showing you what I've done so far and what I'm doing now. So upcoming in the next few months, we're planning this right now. I'm going to be taking these conversations directly to cancer care service providers. So if anyone in the room has suggestions, I'm working on a list of folks I need to reach out to, but recognizing the importance of including that perspective in this as well. And then inviting folks from those discussions to join an advisory board as we try to actually build out an intervention to test what that could look like and do for women in these communities. And I've just put some notes down here from other things that have come up in this work that aren't necessarily the intervention, but are important areas for future research as well. You know, better understanding other household exposures we're not currently capturing, those missing occupational exposures for women who are working, improving guidelines, right? Building that evidence to say, well, if you're a non-smoker, what could qualify you for lung cancer screening? And of course, you know, recognizing the value of community health workers in this space, how do we actually streamline and help them to do this work, whether that's through technological supports, actual reimbursements from insurance, which is something that's being more and more implemented in different states. So how do we help make sure that if this is the right way to go to support women with some of these healthcare needs, how do we make sure that works realistically in these communities? So I will stop there. I have a thank you here to everyone who's helped me with this project along the way, including the Penn State CTSI Community Engagement Group, who helped me recruit some participants for these focus groups. So I will stop sharing my screen and we can open it up for questions.
Thank you so much, Dr. Thompson. That was so interesting and, you know, so close to home. So I think that was wonderful. Does anyone have any questions for Dr. Thompson about her research or about anything related to?
You have a question, Beth?
Hi, yes, thank you. I really enjoyed so much hearing about the work that you're doing. And I was curious about, it sounded like, you know, your participants were very open, you know, to engage with you. I was just interested in sort of what that was like. And yeah, thanks.
Yeah, I think that's something that maybe it doesn't always surprise me, but it does surprise me sometimes how willing people are to share their experiences. And I try to capture the community perspectives, but oftentimes folks are sharing with me their personal relationship to lung cancer. I think many, not just women, but in our Appalachian communities, lung cancer is so prevalent that most people know someone who's gone through this. So it is a very personal thing that they've seen and experienced. And I think hearing one person open up and share kind of opens the doors to others. I mean, hopefully some of that's me and having training as a qualitative researcher and helping facilitate, you know, open conversations. But I think it's about, I mean, trust is always the word that we use about community engaged research, and, you know, having great partners that can help introduce you to folks, make those connections. You know, Penn State CTSI helped me make some connections here to recruit people. And when they're recruited from sources that they trust, that also helps engender open and honest conversations when they join, because you already have that person who's given that, I think we use the word warm handoff, who they do trust, who kind of helps bring the trust into the conversation as well. So I think it's a combination of things, but yeah, I appreciate that, because I'm always grateful when my participants are willing to open up and share.
Do we have any other questions? I have a quick question. So while you were presenting, I was thinking about, you know, the states that you're talking about are, I think, pretty high growers of tobacco. And I wonder,
Yes.
like, how is that going to affect policy change? You know, you're kind of dipping into their money and
Yep.
yeah, you know, people don't
That's
like
a
when you
great
mess with
question.
their money. Yeah, so
Oh, it's been interesting. So I actually, my background, I started out doing more sort of diet, physical activity, stress, sleep kind of work, more cardiovascular disease oriented, even though tobacco is also a risk factor for that. And I kind of shied away from tobacco research for a long time because a lot of my mentors were like, I don't know, do you want to get into that? Because it's a tricky topic. And I think what really bolstered me was hearing from that needs assessment, not just our partners going, hey, this is still a big problem here and we are not doing enough. We want to reprioritize this. And the community saying the same thing helped me go, okay, this isn't just, I shouldn't shy away from these conversations just because this is a tricky, it could be a political situation as well, depending on
mhm.
what, who supports what industries. I had a great quote from a participant in Kentucky. So, as with Penn State, UK is the land grant school in Kentucky, and they have extension offices throughout the state. And she said she went into her local extension office, and they had on the same wall, on one side, they had information on tobacco cessation programs, and right next to it, they had the best tobacco to grow in Kentucky. So, because they also facilitate agricultural work as well. And so I think this kind of conflicting experience, especially when you have folks who sort of generations of their family might have worked on tobacco farms, for example, complex interactions with these industries and kind of understanding, okay, they bring money into my community, they might help put food on my table, but there's these health risks associated. How do we have these conversations and just being open to at least start it and see what people are willing to share with you. Thanks for the question.
Mhm. Nobody else has any questions, we can end it for today. I want to thank you all for coming and listening to the presentation. I hope you learned something. Our next TSS is going to be next month in November. We will advertise that in our CTSI newsletter. So if you're not receiving that, please visit our website and sign up so that you can hear of all the great happenings that go on here in our Penn State CTSI. Thanks again for coming.